Good morning, and I'm so happy you're all here. This has been a long journey for us to get through COVID-19 season, changes to the program, but today we are all together here. I couldn't be happier, and I hope that you are taking some time to enjoy this mask, which is an awesome product of our team, the CDPH team and the PANG team. My name is Tracy. I'm the president for the California Parkinson Association, Northern California, and I wanted to welcome you to today's event. If you registered in time, you will get one of these cool masks, you will get a cool program, and you will get a very cool conference notes to take notes about all the great things you hear today and all the great things you want to follow up on for resources about the registry and about resources for people with Parkinson's or their caregivers. We've engaged this conversation and this work with the California Department of Public Health because we're dedicated to helping people with Parkinson's, their families, and their caregivers. We live the motto, building community for the journey. PANG believes strongly that community is built by effective partnerships, a shared vision, collaborative programming, and we're not alone. There are many organizations who are serving people with Parkinson's across this country, particularly in California, and for us, particularly in Northern California. We share resources, we share referrals, we share data and education. It's not about us, it's all about you, about what we can do to help you through your journey. Here are some organizations that do help and have been really great partners with us. Parkinson Foundation, Michael J. Fox, Brian Grant Foundation, and the PMDA, the Parkinson Movement Disorder Alliance. We're pleased to work with them and pleased to continue serving you. PANG is honored to be a partner with the California Department of Public Health and the Parkinson's Disease Registry team. We're here today to shine some light on this national model. And I talk about a national model because California is unique relative to collecting this data, protecting your data, sharing this data, and informing the public about the impact of prevalence and incidence of Parkinson's disease in California. People across this country are looking at this as a model for their states. We've done it in California, and you're going to benefit from it long term. Think about this. For the first time, we're going to have gender, ethnicity, age, zip code. All that data will be available so people can understand the impact of Parkinson's across the state. You could talk to your neighbors, talk to your friends, talk to your elected officials, talk to organizations about the importance of helping people with Parkinson's. These data points and this information you'll see once we shine light again and again on this registry are going to be very helpful in improving services, ensuring support, and ultimately finding a cure for Parkinson's disease. The data will help us discover the prevalence and incidence, and we'll use this data to educate policymakers and organizations and communities about the needs you have for your journey through Parkinson's. Today, we are building, and we're learning, and we're working toward finding a cure for Parkinson's disease. We are committed to that mission. We are committed to be with you. We are committed to the support you need. And always remember, we are here for you, and we are all about you. One of PANG's favorite slogans is, "Until there is a cure, hope and healing every day." This is where we're at today, a lot of hope, but the data is going to bring us more information and more substance to finding that cure and to finding a solution to Parkinson's disease in terms of services and support you need through your journey. It will be a better tomorrow for all. I've talked about partnerships and how important they are to us and how important they are to you. And PANG has an opportunity to work diligently and collaboratively with very dedicated, smart, and compassionate public service professionals in the California Department of Public Health. We've all had our experiences with departments and bureaucracy and systems that kind of don't work the way we expect. I'm telling you, the CDPH folks are totally committed to this project, totally committed to the purpose, and they care as much about this data as we do. So important to have that partnership, understand that they too are committed to making sure this is right, this is accurate, and this is helpful, and that it can be useful for policymakers and program decisions for the years ahead. It was apparent to me that these folks care so much about you and care about getting this right. We'd love to have everything for you today. We'd love to have a full report. We'd love to have all this great information. Today we're going to shine a light on what it looks like because it's going to get better and bigger in the years to come. Today we're going to give you some good details. There are many people who work at the Department of California Parkinson's Disease Registry, and they deserve acknowledgement for their dedication. And I just want to point them out on the slide you're seeing today who those folks are and their names. They are real people. They are really committed to this program. And sometimes we get lost in the bureaucracy and the organizational structures, but every day these people are working to make this registry work right for us. Before I introduce the next presenter, just a reminder that on your screen to the right is a Q&A button. If you have questions for this session, simply click the button and a box will pop up. Type your question into the box, and we are monitoring this forum live and we'll answer many questions as we can during today's broadcast. If I had it my way, you'd all be in this room right now shouting at me and asking questions. We'd get the experts to come up and we'd engage. You'd talk at your tables. We'd go to conference rooms. We'd break out. We'd have flip charts. We'd have Post-it notes. But we're in a new world. COVID has changed things, and I think we're going to have to maximize this opportunity for you to participate. Ask your questions. Now's the time. The experts are here, and you've got to be curious. This is the first time we've released this data, and so what is it? What does it do for me? How can I use it? And importantly, what can you do to educate your neighbors, your elected officials, and your communities about this data so we can get more resources for people with Parkinson's? I am very pleased and honored and have a great sense of respect and appreciation for a gentleman who you're going to talk to next, or hear from next, I guess, in this virtual world. Dr. Mark Damison. Mark is the director of the California Parkinson's Disease Registry. He's worked with CDPH, California Department of Public Health, since 2008. He holds a doctorate for public health epidemiology and has worked with public health surveillance since 1994. And that's all impressive. He's a smart guy. But in so many instances along this way, when COVID hit, when budget hit, when other priorities were taking over, Mark stayed the course. He said, we're going to do this. We're going to get it done. And it's important that this group hears from us. So I'm grateful for Mark being here, and I'm grateful for the whole entire Department of Public Health sticking through it, through a pandemic like we've never seen before. But this is such an important issue. They too are with us, and they're with you. So thank you for being here today. Mark?
Thank you, Sean. It's a great pleasure to be here, and I really want to thank you as the Parkinson's community for joining us today for this conference. I want to start by resonating to the theme of the shedding light. Not only are we going to shed light on the Parkinson's Disease Registry today, but I also want to emphasize that the Parkinson's Registry, the California Parkinson's Disease Registry, or Cpdr, is designed to shed light on the greater Parkinson's disease situation in the state, and from there be applicable to the rest of the nation and even the world. The Parkinson's Disease Registry was begun, really falls under two California governors. The first bill that authorized the registry was actually in 2004 under Governor Arnold Schwarzenegger. However, the registry, as it currently stands, was initiated under Governor Brown. Now, I want to read the quote that Governor Schwarzenegger wrote when he authorized this bill. I am directing the Department of Public Health to work with scientists, medical professionals, and advocacy and patient groups to develop an appropriate model to ensure the most accurate reporting of Parkinson's disease. Now, with that directive, the Parkinson's Disease Registry began in 2017, and this was, what you're seeing now is the bill that actually made that happen. This was SB 97, and it modified some of the law that's in place. But the main point for you is that it brought about the California Parkinson's Disease Registry, which is known as the Richard Paul Heyman Cpdr. Now, the first question, why do we need a registry for Parkinson's disease? Now, as you see in this slide, Parkinson's disease is affecting over 1.5 million people in the United States, and about 70,000 are newly diagnosed per year. That makes Parkinson's disease the second most common neurodegenerative disease, surpassed only by Alzheimer's. Parkinson's is also the 14th leading cause of death in the United States. Parkinson's is affecting both young and older individuals, although it predominantly is in older age groups. Parkinson's is caused by genetic and environmental factors, but one of the main reasons that we instituted the registry is because we really don't know a lot of the causes of Parkinson's disease. Understanding Parkinson's will aid greatly to further clarify the steps related to the disorder. It will help us to better understand the distribution of it, as well as how we can eventually both prevent as well as develop treatments and ultimately a cure. So I wanted to back up a little bit and talk about the worldwide situation. The global burden of Parkinson's disease is expected to increase greatly, as you can see from this slide, over the next, really this century. This is covering over a century and a half. And you can see with the black arrow where we are at now, what you can see in the lines is increasing rates of Parkinson's disease worldwide. The world is indicated by the blue line, and then you see the various continents indicated by the other lines. And particularly I want to point out that North America is at the top of that. Now I want to also talk about the global burden and its increase with a map. You can see here where we're seeing the greatest growth and we're going to be seeing less growth. Now I want to say we don't have a lot of data on Parkinson's yet, which is another reason why we are here, why we as this team, who Sean spoke to, are working so hard to create the California Parkinson's Disease Registry. Now, I want to talk a bit about the consequences that Parkinson's has in society. This is probably not new to many of you, but I think it's very important to go through because it's causing a lot of things in our society that we could help to prevent, and that's what we're here to do, is to try to help prevent and cure, or really treat at this point and cure ultimately. So I want to start with some research that was done by the Michael J. Fox Parkinson's Foundation. And they've done some really good work in the area of looking at what are the costs to America, and the world really, but they focused in America, of Parkinson's disease. Now, these are going to be some staggering numbers I want to share, but they're very well researched. The direct medical cost of Parkinson's is estimated to be about $25.4 billion. These are annual costs. The indirect medical cost is about $26.5 billion. Now, those are things like loss of years worked, lost societal contributions, mental and physical costs, and also the effects of family members, colleagues, and friends. So this brings us to a total of about $52 billion per year, 51.9 exactly. So the true impact of Parkinson's has previously been underestimated. That's what this study by Michael J. Fox showed. So we are here with the Parkinson's Registry to add more data to better understand how we can control the impact of Parkinson's as well as these costs on society, these direct costs in the medical area. And this information is going to help us in all these areas. Now, the next place I want to go to is the team aspect. Sean talked about this, and it's the case here when we're having this conference today. It's the case in your community locally. It's the case, of course, larger in the city as well as the state and national levels. But team efforts are the key to any success. The same goes in any sort of scientific endeavor like the Parkinson's Disease Registry in California. The team is composed of multiple people, but primarily our core group has epidemiologists, there are healthcare providers, there's basic scientists, and then the people and family and friends who are living with Parkinson's disease. And that includes you. Now, getting to the rationale, why was this done in California? One point I want to make, and it's a very important point to take, is that we are one of only 4 Parkinson's disease registries nationally, only 4 states, and we are the most comprehensive Parkinson's registry of all of those. For that, I want to thank you as the community of advocacy. I want to thank the larger community of our taxpayers, because it's with that, and of course our legislative leaders. It's only with that kind of commitment that we can do this kind of work. Now, the thing that comes to mind as we think about the registry, why California? Now, we have a number of things that are happening in the state which make it an ideal place to establish a registry, especially perhaps the most advanced registry in the country for Parkinson's. We have a very strong scientific community dedicated to the eradication of Parkinson's. We have mandatory reporting of pesticide and toxicants use for decades. We're a national forerunner in the area of environmental surveillance of pollutants. We have a strong track record for environmental research, and we have a rich diversity of resources to provide an ideal climate to investigate risk factors for Parkinson's. Finally, we have a long-standing experience in disease registration, surveillance, and a network of interoperability in the technological area, which makes California, again, ideal for Parkinson's registry. So, what does the registry do? Now, I know that when you think of a registry, you think of shedding light, like Sean said a couple of moments ago. You think of looking at a large population. You think oftentimes of questionnaires. Well, we're not doing that here. You think of information that informs public policy. Yes, we're doing that. So let's look at the basic elements of the registry and what it can do. So first, it provides the most accurate approach to determining the number of people who are affected by a disease. Of course, with knowing that number of people, you can then determine what kind of genetic, environmental, or behavioral things might be impacting the disease, might be causing it, might be taking those who might already be susceptible or have a genetic disposition and make it happen faster. These are all things we need to be thinking about. Third, it helps us to identify whether the number of people living with Parkinson's is increasing. We want to know, are things getting better? Are they getting worse? We want to know, are there certain areas where it might be getting better or it might be getting worse? We might want to know if there's certain groups of the population where it might be getting better and worse. And when we say groups of population, we typically in epidemiology are thinking of age groups, gender, we're thinking of race, ethnicity, we're thinking of sometimes income groups. But we want to be able to know these things about Parkinson's. So in summary, a registry, the Parkinson's Registry, will provide a systematic way to look at Parkinson's and look at potential other risk factors. Now, what kind of data is being collected? So that's why we would have a registry. What kind of data is being collected? We have demographic information. We have information about the healthcare provider themselves. And then we have basic clinical information about the diagnosis. So with that, we can have a description of the person who is impacted, the person living with Parkinson's disease. We know about their provider, and then some of the things that are clinical information, so that we're then able to inform some of these larger decisions around how do we better do clinical treatment? How do we better do prevention? How do we better understand and support the community who is impacted or affected or living with Parkinson's? So how will the registry data be used? So first, we want to look at things what we call epidemiologically. Epidemiologically means looking at how the disease or the condition is spreading over a population. You can think of it in terms of the different parts of the word. Epi is over, demos is people. So epidemiologically means we're looking at something, how it's working in the people group. Whereas your provider, your doctor, is looking at you individually. We in epidemiology, and particularly in public health as well, are looking at the larger population and what's happening. So then we're able to then describe some of the things I mentioned earlier. In what areas, in what groups is Parkinson's disease most affecting people? Where is it increasing? Where is it decreasing? This is the ultimate goal of the registry. So we want to also then, within a very controlled environment, be able to share this data with researchers who are investigating the Parkinson's risk, so that so that those people, because although the state has a lot of dedicated people, and the Parkinson's program individually has a dedicated staff, as Sean mentioned earlier, we can't do it all. Our objective then is that this information will be made available to researchers, clinicians, who can use it to better their practice, to better describe, to better understand the Parkinson's situation in California. So those researchers can access the data, but I want to make a very important point here, that they're required to abide by very strict data security and confidentiality protocols. These researchers will not have information which is going to be able to be shared more widely. And the other thing in this use of the Parkinson's disease registry data is that no data will be able to be used unless it is approved by what's called an ethical committee. And you've probably heard of that. We call them institutional review boards. They go under what you might have heard of as the HIPAA, or Health Insurance Portability and Accountability Act. There's federal and state laws which really protect the data that's in the registry. So that leads to the next slide. So when we're collecting the data for the registry, there is not an informed consent process. However, the data is, so you're not going to hear from your provider when your records go into the registry. It maintains, there's a strict confidentiality and very, very strict electronic protocols which protect the information once it's in the registry. All data is managed with encryption, protection, the latest, and what we're talking about in this slide is the latest that we're able, and greatest we're able to do now. But as the field evolves, the registry is utilizing these technologies to better protect you, to better protect the person whose information is in the registry. Finally, I want to share that no information will be shared with the Department of Motor Vehicles or any other government agency. Every user of the information needs to go through the same strict protocols that were described in the slide before. It needs to be approved by independent committees, and then they need to stick to strict adherence of confidentiality and security protocols. With that, it's my great pleasure to introduce Dr. Thomas Avino. Tommy is the lead data scientist for the California Parkinson's Disease Registry, coming to us with a doctoral degree, which he received in 2014, after which, before he came to the registry, he was a postdoctoral fellow at the UC Davis Mind Institute, one of the premier institutes for neurologic research. Now I want to introduce Tommy Avino. Tommy is joining us remotely. Tommy, take it away.
Thank you very much for that introduction, Mark. I'm happy to be part of this conference today, joining you all remotely. Today I'll be discussing a little bit about how the data flows into Cpdr, what we've learned so far, and what we intend to do with the data moving forward. So the first part I'd like to discuss is how data is sent to Cpdr. And this graphic on the left, we can see the data flow. And step one shows data submission. And I'd like to really make the point here that the data is submitted to Cpdr directly from healthcare providers. There is no responsibility on behalf of the patient to submit their data to the registry. This is all occurring behind the scenes directly from the medical providers. And the graphic on the right here shows some frequently asked questions that we get into the registry, and they correspond with kind of this data flow, so we'll go through them together. And the number one question we get into the registry is, accordingly, do I, as the patient, have to do anything to get my data in? And the short answer is no. All of those reporting requirements are put on to the healthcare providers. And when those healthcare providers do report to us, they have the option of submitting through two methods. They can submit automatically through the electronic health records, or they can log into a secure web portal through CalReady and submit cases manually. And if we look onto step two, we can see that the second phase of this data flow is quality control. And really what this is all about is making sure that the data that is sent to us is complete and does not contain any missing or invalid entries, and is just overall a comprehensive Parkinson's record. And accordingly, we often get a question into the registry of, if I have multiple doctors, if I see multiple doctors, are they all required to report? And the short answer to that question is yes. If you are seeing multiple doctors, and to the providers that are listening, you should not be relying on another healthcare provider to submit your Parkinson's patient to the registry. All of these rules, by the way, are outlined in the Cpdr Guide to Reporting, which again details the criteria and the format and all of those specifications required to submit data to the registry. And if we move on to step three, we see that directly coming from that quality control is a process of deduplication. And really this is just a way of saying we want to make sure that each patient that is in the registry is counted only once. As we'll see in the next slide, we have hundreds of thousands of records that have come into the registry so far, but only a fraction of those are unique Parkinson's patients. So we go through this process of deduplication to ensure we're counting each patient once and only once. So if, for example, you do have multiple doctors and they do submit records, all of the records to the registry, we have the process on our end to count you once and only once. And an important part of that deduplication step is the linkage with external records. And I'll touch on this a little bit more on the last part of my presentation. But one of the more frequently commonly asked questions we get into the registry is, does the California Department of Motor Vehicles receive Cpdr data? And unequivocally, the answer to that is no. When I say, or if you see researchers say that we are linking data with external sources, it really means we're bringing data in from an external source and overlaying it onto what we have already in the registry. But again, more on that on the last slide. Moving on to the final part of the data flow, we see that really, this is really what the registry is for, is the data use and the data disclosure. The data use really, I see that responsibility is firstly falling onto the registry to produce preliminary and basic epidemiological and surveillance measures such as the incidence and prevalence of Parkinson's disease. And it is some of these basic measures that I'll be discussing with you in the second half of my presentation. But again, I just want to make the point that that is the first primary role of the registry in the data use, but maybe even more importantly is our ability to make that data available to researchers to even broaden our understanding of Parkinson's disease. So I and actually Drs. Damison and Kandar will be discussing a little bit more about the data disclosure later in the conference as well. So moving on to the next slide, we're really getting into the data here, and we can start to see some of the indications about how much data we've processed and how many unique cases are here. So the graphic on the left shows exactly that. The outer ring shows the number of total records that have been submitted to the registry, and this is important to note, this is the data as of May 31st, 2020. Cpdr has received over 272,000 records. And if we look to the inner ring, we can see that the portion of those total records that are actually unique patients is 71,671. So really, on average, we're looking at about each patient, on average, gets reported about 4 times to the registry. So again, emphasizing the importance of that deduplication process. And for both of these rings, you can see really just the proportion of how many of those records have come in through an automated electronic health record, or how many have been submitted through the CalReady portal. And that table at the bottom really provides a breakdown of the unique number of facilities, patients, and the total number of records we've received for each reporting method. And now, again, I would just like to emphasize that this data is incomplete so far. Not all of the healthcare facilities in California are reporting to the registry. So this is what we have so far, but we also know that we still have a little ways to go to achieve complete reporting of Parkinson's in California. Moving on to the next slide, we're starting to see now some of the basic demographic factors associated with the California Parkinson's disease patients. And the 2 demographic factors I'll be discussing today are age and gender. And the graph on the left shows both, but let's just discuss gender first. The men are shown in the blue squares, and the women are shown in the orange triangles. And we can see that for every age group examined, we in the registry have a higher number of men in that age group relative to women. And moving along the x-axis, we can see that this is true for every age group. There is a higher number of men than there are women. And the second component of these demographics that I'll discuss today is the age component. So yes, the men we have more men than women with Parkinson's disease in the registry, but think of those 2 lines together. Over time, we see a drastic increase in the number of patients with increasing age. We see those lines going up as we move further up the age groups. And so the graphic on the right kind of distills these points in that the number of patients with Parkinson's disease over the age of 85 is about 6 times more than those under the age of 55. And concordantly with regard to the gender discrepancy, we see a male to female ratio in our current patient population of about 1.5 to 1. And this is interesting because it's replicative of some of the scientific findings that have been published in the literature already. So we are starting to see some of the trends that are well known in Parkinson's disease, such as the increased risk with age and with gender. Going on to the next slide, we see the geospatial distribution of Parkinson's disease across California. And on the right, we see the top 5 list with the counties with most Parkinson's patients. Again, I'll make the point here that this is just the number of reported Parkinson's patients to the registry and does not yet reflect a prevalence estimate, simply because we are still trying to achieve completeness in the registry. Nonetheless, this map here and this geospatial distribution provides an indicator as to where we're seeing some of the Parkinson's patients reside. We see here it's heavily in Southern California, again, related to more populous counties. But it highlights what we intend to do with linking with external data sources. And I talked about this a little bit on the first slide. Data like this would be really important for linking with environmental toxic data to examine, those environmental hazards that may be related to Parkinson's disease. I had mentioned some hospitalization data as well. This would be really important for us to get a determination of facility coverage. If we can see that there are facilities in certain counties that may not be reporting to the registry, we can then follow up and begin to, or continue rather, to achieve this complete reporting for Parkinson's disease throughout California. So it is really all of these goals and all of these steps that are taken to try to improve the surveillance capabilities of the registry and in turn be able to provide this data to the researchers for even broader research. And moving on to the last slide, I want to discuss some of the highlights and concluding remarks from this bit of the presentation. I mentioned it a couple times, but because it's so important, the data here do not yet reflect a prevalence estimate, and we are working towards onboarding all of these facilities, and in the meantime we are in the process of estimating facility coverage so that we can determine of the patients we currently have in the registry, how much of them are representative of the total population. And however, despite these limitations, we are able to see and replicate other epidemiological findings that have been shown in the literature, such as the association with age and gender. And finally, a really important part of the registry is to make this data available to researchers, and that application process will be published on our website. You can see here www.cdph.ca.gov/Parkinson's. This is a great resource for all of our patients, for all of our providers to check in with us, to contact us, or to check in for updates to see when this disclosure protocol will be ready. You can check in on reporting deadlines and things of that nature. So after all this data, it's time for a break, and I'm going to turn it over to Christine Shade, who is our movement specialist. She has a doctorate in physical therapy, and she is going to take us through some exercises to get that blood back running. So off to you, Christine.
Thank you, Tommy. Let's all get moving. I'm Christine Shade. I'm a neurophysical therapist at Kaiser Permanente in Roseville. So we've been sitting for a long time, so now we need to get moving. Everyone's really stiff. So we're gonna first start by just taking a nice deep breath in your nose and breathe out your mouth. Good, and now let's start rolling our shoulders back. As you roll them up, back, and down, everyone should feel some nice clicking. Good. And you wanna focus as you're moving, make sure you're moving really big. So I don't wanna see anything really small. We want really big shoulder rolls. Good, now try going forward. And you can smile at the same time, act like you like it. Good, we're working those face muscles. Good. Perfect. Now, since everyone is sitting, I'd like us to just warm up with reaching forward in front of us. Good, and pulling back behind us. And reaching forward. Good, and pulling back. When you pull back, squeeze your shoulder blades together. Good. Reach forward with big fingers, spread your fingers out. Good, and pull back behind. A few more. Good. Nice, so we should be getting nice and loose and getting ready to stand up. So our next one we're gonna actually come all the way up from the chair. So your options are, you can always hold on to the side of the chair and you wanna lean forward and stand up tall. But the key is scooting forward to the edge of your seat, making sure your nose goes over your toes before you stand up. So you want to scoot forward, lean forward and get your nose over your toes, and then push forward and up. Perfect, so let's try that 10 times. Ready? Let's go. 1, and back down. Sit down nice and slow. 2, and back down. 3, and back down. 4, and back down. 5, and back down. 6, and back down. 7, and back down. 8, and back down. 9, and back down. And 10. Perfect. So don't sit down, stay standing. Options for modifying, we are gonna march in place or jog in place, or you can sit and march in place. So all of those are your options. I'm gonna show just back by the chair so you can stand and hold on to the chair if you want. And we're just gonna march in place. And I wanna see a nice big arm swing on one or both arms and high knees. Good, and relax your shoulders. Stand up nice and tall. So you've been sitting for a long time, so we're just trying to get that blood flowing. Good, and you can make a surprise face with your eyebrows. Good, to get those facial muscles going. Good. Perfect. Now let's try some modified jumping jacks. So options are, you can bring your hands together and step out with one foot and then bring your arms down and then switch. Or if your balance is not quite there, you can hold on to the chair with one hand and bring one arm out and one leg out and bring it back down. One arm out and bring it back. If you were sitting in a chair, you could bring both arms up, foot out. Both arms up, foot out. Okay, so we're gonna do that for 30 seconds. Here we go, ready and go. Good, and again, we're trying to work on that posture at the same time, so stand up nice and tall. Good, make sure your fingers are nice and wide. You're doing really good. Make sure you're breathing. Your face shouldn't be turning red. Good, just a little more. Good, keep going, keep going, keep going. Perfect. Good. Now we're gonna do some calf raises and finger flicking. So I wanna see, options are just standing and raising up on your calves and flicking your hands nice and big. The ways to modify are, you can hold onto the chair and come up on your toes and flick. You can also sit down and come up on your toes and flick your hands. Good. So those are the 3 options. I will show the middle option. So again, I'll hold on to the chair and we're gonna go for 30 seconds. So you wanna push yourself. You wanna try to move fast, but safe. And really think about those hands and really flicking hard. You should hear yourself flick your fingers against your skin. Good, and really force those fingers nice and wide. Good, just a little more. Keep going, keep going, keep going. Good. Perfect. Now we're gonna reach. So I want you to take one arm and your opposite leg and reach up high and look up at your hand. Perfect. You can also modify and hold on to the chair if you need to. So if I stand behind the chair, I'm gonna reach up, look at my hand. Good. Reach up to the other side. If I was sitting down, I could reach and just put my opposite leg out. Good, and we're gonna do it for 30 seconds. Here we go. Good, make sure your head is moving and you're looking at that hand. Fingers wide. Keep going, keep going. Make sure you're sitting up tall or standing up tall. Good, very good. Now, we're gonna do some foot coordination. So let's see if we can try, in sitting, you would step out with your foot, out with your other foot, and then step in. If you're standing, you can either hold on to the chair and step out, in, or if you don't need the chair for balance, you can just stand and work on fast feet. So we're gonna go for 30 seconds and really work on that coordination of your feet. Here we go. So you're gonna step out, in, out, in, out, in, out, in. If you lose the coordination and you're starting to get your feet a little bit jumbled, just stop and take a deep breath and then restart. Now step out, in, out, in, out, in, out, in, out, in, out, in. Good job. So now let's see. We are going to loosen up our trunk a little bit more, but involve some trunk rotation. So what I like to see is I want you to stand like a big T. So you're going to squeeze your shoulder blades together in the back and stand with your feet nice and wide. You're gonna stand up nice and tall. And we're gonna start with your right arm and you're gonna rotate over and clap your left hand. So I'm also pivoting on my right foot. So I'm gonna open up wide and we'll do it again. We'll rotate to the side, clap that hand, open back to the middle. Modification options would be, again, if you're standing, you can always hold on to that chair. You'd put your arm out, rotate to the side, and then back open. If you were sitting, again, you would sit away from the backrest. You'd sit up nice and tall, open your arms, rotate to the side, and back open to the middle. Okay, so let's go. We're gonna go for 30 seconds. So open those arms nice and wide, squeeze those shoulder blades. Good, we're gonna start going to our left. Ready, and go. So I wanna hear a nice loud clap. Open back to the middle. Every time you come back to the middle, you wanna reset those shoulder blades and squeeze them together. And make sure you're following your hand with your head and your eyes. Good, just a few more, keep going. Very good, very good. Okay, let's come back to our chairs. And I wanna see, as we're sitting, I want you to scoot all the way to the edge of the chair. Put your feet out in front of you, and I wanna see you kick those legs. So I want you scissoring them in front of you. You could hold your belly in tight and make sure you're breathing. That's the key part. So we're gonna go. I want everyone joining me, so make sure you hold on to the side of your chair and just kick those legs. So you're gonna go up and down, up and down, up and down. As you're kicking them, you can tell whoever's with you or talk to the camera and name all different kinds of animals that you can think of at the same time. And stop. Perfect. Now we are going to hear from Sandy Kwong with the CDPR. Thank you.
Thanks, Christine. That was awesome. Before I introduce the next session, just a reminder that on your screen is a Q&A button. If you have a question that you would like to ask, simply click the button and a box will pop up. Type your question into the box. We will answer as many questions as we can live. Additionally, we will send out a follow-up email and a summary of the questions and answers. When you signed up for the conference, we asked you a little bit about yourself. The results show that more than half of you are persons with Parkinson's, and a quarter are caregivers. And the other quarter includes family members, medical professionals, and resource support services. We also asked what county you resided in. Of the 58 counties in California, we have 34 represented and attendees from 5 other states, including Arizona, Idaho, Indiana, Nevada, and Washington, D.C. Our next session will prove to be a dynamic conversation between 2 experts in the field of Parkinson's disease. Please welcome back Dr. Mark Damison.
So hello again. It's really good to be back with you. And I'm really excited about this next session that we have in the conference. In this next session, we're going to try to give you some information about the registry itself through the perspective of 2 professionals who are both very much involved and engaged with the data. One is myself as an epidemiologist and the director of the registry, and the other is Dr. Suketu Kandar, a movement disorder specialist and Parkinson's disease doctor here with Northern California Kaiser. I wanted to say a little bit about Dr. Kandar before he comes, because he's done a lot of things which are hugely important for this community. So as I said, movement disorder specialist, he is the medical director of the Comprehensive Movement Disorder Program. He has a fellowship in Parkinson's disease and movement disorders at UCSF. He works with a team of specialists focusing on Parkinson's disease, essential tremor dystonia. He has been a champion of multidisciplinary care using an integrated practice model, and he currently serves on the board of directors of PANC. I want to now welcome to the stage Dr. Suketu Kandar.
Thank you very much, Mark.
It's great to see you again.
It's always nice to see you.
Yeah. So first, just a huge thanks for being here. I mean, I know your schedule is busy, and I know that these are special times, but we're really glad that you could take the time to come and talk. And then we can have this conversation so that those who are watching can understand a bit better how the registry, because a registry is sort of by nature a bit data, it's sort of in the background, connects to what you do. You're the person who treats the patients themselves. You're the front line, really. So with that, I wanted to actually just ask you a question that gets back to Dr. Thomas Avino's presentation from a few moments ago. And that is this. Given what you have seen well, I mean, you know the registry quite well, but also in Tommy's presentation, what is the most encouraging thing you've seen in the results and the progress of the registry thus far?
That's a very good question. I think that Tommy gave a wonderful talk on what we've learned so far from the registry. And clearly, there's a lot more information that we want to know. But what I find encouraging is that everything that I've seen in my clinical practice is certainly in line with what you guys are noticing from the registry. We're seeing a certain age group that's more susceptible to Parkinson's disease. Men being more susceptible to women. Mm-hmm. Certain areas with high concentration of certain ethnicities and certain populations being more susceptible. This is clearly what I see in my practice. And because we're seeing the same thing, both me clinically and you objectively through the registry, it encourages me that future results from the registry are also going to be equally encouraging. I think this is very important,
right?
Not just for what we understand now, but what we hope to understand in the future.
Right. Well, I appreciate that. And just to kind of lay it from that, we're also interestingly seeing a similar distribution for what the Michael J. Fox found when they did a survey back a couple of years ago. So the results we're seeing, like you say, they're mirroring what you're seeing in the clinical practice and in the Parkinson's world, and they're also mirroring what Michael J. Fox Foundation did.
You know, when I did my fellowship, we always quoted certain numbers when it came to how many people are living with Parkinson's in this country. and what's the age distribution, and what's the gender distribution. And it's always the same numbers. It's been the same numbers. Roughly 1 million people in the United States at risk of developing Parkinson's disease. And it's only been in the last few years that we've seen some of that data become more granular. And I think this registry is even going to further granularize that. So I'm really appreciative that you also in your talk mentioned about the healthcare costs, indirect and direct, that the Michael J. Fox Foundation back in 2017 had understood as to what the healthcare cost is to treating Parkinson's disease and all of its indirect effects. So that kind of goes back to what I want to ask you now.
Okay.
Is there anything that my patient needs to do to help comply with this registry, or is this all on me and my healthcare colleagues?
I'm really glad you asked that question, Siketu, because I really agree that we want patient care to be about patient care. We want to have your time with your patient to be focused on your connection to that patient. Your focus on really helping that patient and I know, well, we all know that Parkinson's has a lot of impacts in different parts of your life. We don't want you to be having to take down data and spend time, have your staff spending a lot of time with that. So we also don't want that to be interfering with your interaction with the patient. So no, there is nothing that needs to be asked directly by you. This data is coming from what is already being collected from your what we call patient record.
So that also then begs the question as to what data is actually being collected. And through this program, we've had a lot of registrants. Many registrants, of course, have also questions regarding this registry. And this specific question actually came from a person from with Parkinson's from Granite Bay up here in Northern California. So the question is, what data is being collected? And if I were to add a little bit to that, I remember back when he talked a couple years ago when this registry first came to light, it was asking for quite a bit of data, more data than I was able to supply for each and every one of my patients, right? 4 pages worth of information when it came to medications that you've been on, medications that a patient might be on, medications that patient had side effects to, as well as what their current stage of their disease is and whether they've had deep brain stimulation surgery or not. And we were able to pare some of that down. So can you maybe help us understand what data is being collected now?
Sure. And I really appreciate your asking the question because I think the people who are watching are also very, very interested in that question. I mean, it's very important to know how is my information being used? What information is being stored? As I said a little bit ago in my opening presentation, there's absolute confidentiality and security around the data that's being collected. It is being collected utilizing the most stringent and most secure algorithms available. There's under a lot of government law which protects the data in terms of not just who can use it, but also how it's used. So I think what I want to tell you is that it's very secure. Now, as regards to what is there, which I think is the question you're after, what is there is actually also very minimal. So in addition to the fact that any data that we receive is being secured and very limited as to anyone who can touch it, we have yearly annual protocols for security for anyone who touches our data in our office. It's only 12 data elements actually that are actually being collected on each client.
It's only 12 pieces of information that you need about a patient to help the work that you're doing.
Correct. In order to look at the distribution of really what I call epidemiology. As I mentioned a little earlier, epidemiology is looking at how the condition is spreading over the population. So we don't need the level of detail that you as a clinician need, of course, because you're treating you need to know details about that patient. So we are able to collect at this point the things like the zip code, we collect gender, we collect race, ethnicity, we collect of course what the diagnosis is that you have done as a clinician, and then a few other data elements which help us to contextualize it and make these population-based statements and things that will help us to then track where the condition is.
So I remember when we had these original conversations a few years ago, and there were so many data points that the registry was requesting. In an effort to be able to better understand incidence and prevalence, both epidemiological terms, it seemed like too much information. And we pared it down to the minimal amount of information that was necessary to understand incidence and prevalence. So can you explain a little bit what incidence is and what prevalence is?
Absolutely. And so incidence and prevalence are what we call epidemiologic measures. They are to tell us in the population what is happening. So there's a difference between the two, although they're related in some ways. Incidence is the number of new reports or cases of Parkinson's every year. That's only the people who newly were diagnosed. The prevalence is the number of existing cases who are in the population. So that includes those who are newly diagnosed, those who were diagnosed years ago, those who, and so as you know, because Parkinson's is it's a disease, it's a condition people live with for a long time, the prevalence is very important to know, but in order to look at things around prevention, you want to be looking at incidence. So prevalence is really important to know sort of how do you care for the people who are affected now, because that's not just who newly got diagnosed this year, whereas incidence is looking just at that. So so that's going to help us understand where it might be coming from, what may be some of the ways we can prevent. So there's kind of two areas that we look at with incidence and prevalence.
So I work in Sacramento. And to try to summarize, just so I understand better, maybe our audience understands better, incidence would be the number of new cases in Sacramento in a specific time period.
Yes.
Okay. And prevalence would be all the cases of Parkinson's in Sacramento. Is that about right?
That is exactly right.
Okay.
And I think related to that, you're talking about sort of what are the things we're trying to look at from the population level. Incidence and prevalence, I think I'm glad that we went over those, because I think a lot of people are not familiar like I am with those. But I wanted to ask you a question on the more clinical side. How can the registry, because like you say, we're looking at these objective measures. Right. New cases in a year in Sacramento, in your example, and then we're looking at number of existing cases in Sacramento, and really that's kind of at any point in time. And as I said earlier, those have kind of different purposes. But because to get that information, we need to be connected with the community who's watching this and others. I wanted to ask you, how can the registry better connect with the Parkinson's community? Better be letting people know what's happening so that not only are they aware, but that they can encourage maybe their providers to report.
Right. I think that this is a question of healthcare access. If you look at Tommy's PowerPoint presentation, right, where there were high concentrations of patients living with Parkinson's, they were in areas that are gifted with a lot of healthcare options, right? Look at the area in Los Angeles or in the Bay Area, right? You got UCSF and Stanford and Kaiser Permanente and so many different healthcare institutions that patients actually have an abundance of places to go if they were to get health care for their Parkinson's disease. Maybe in more rural settings where the communities are a bit more stretched, there may not be as many options. And oftentimes in some of these communities, those options are not really options at all. So it's a question of healthcare access. Are patients living with Parkinson's able to get to their healthcare provider for an annual checkup, for annual follow-up? And the nice thing about the registry is that it puts the ownership on all healthcare providers, not just the neurologist, not just the Parkinson specialist, but all healthcare providers. So giving every opportunity possible for anybody going in for their Parkinson's management or even just for a well visit right? To be able to have this provider, right, be able to send this information over to the registry. We want to collect everybody who has Parkinson's in the state, whether it be in a place as urban as the Bay Area or as rural as maybe the Central Valley.
Okay.
So I think that our job through the registry, our job is to really put that word out there, that awareness out there, and really some onus has to be a little bit on the patient and their loved ones on getting them to be seen by a provider, neurologist or otherwise.
I'm really glad you mentioned that, Siketu, because linked to the question I just asked is how can this data, like I say, this is population-based data. This is data that's it's a little bit on it's contained in computers, right? It's not having a direct contact with the patient. How can this data, the data we're collecting, better help that access that you're speaking to?
So right now, it's interesting, and as much as we're living in a world of technology, right, and a lot of news in this year, I still don't even know how many patients I'm seeing on an annual basis. I don't have a panel per se, the way that maybe a primary care physician would have a panel. Specialists typically don't. And so this data would be helpful to me. Let's say that the data is complete and all movement disorder neurologists or just general neurologists know exactly how many patients with Parkinson's are they following on a routine basis. It'd be great to know that information, because then I can actually book the return visits, knowing that patient A has not been seen in a year or patient B has not been seen in 5 years. It'd be nice to know that information through the registry, so that way I can do a better job with being a provider.
Oh, I appreciate that. Because the purpose, as we introduced at the beginning, or as I introduced, of the registry is to be able to improve the conditions for Parkinson's, people living with Parkinson's and their loved ones throughout the state. And I realize that there's some are having the access they need, some may not have that, or maybe there's ways, even though I hope that everybody who needs the access is getting it, but maybe we can find ways to make it easier. Maybe we can find ways to collaborate with you as the provider, the frontline provider, directly working with the patient, to make your job more easy, to make that access easier for your patients.
I hope so. I think that's going to hopefully be one of the goals of the registry, at least in the short run and definitely in the long run. I think some of the other questions would be, how's this registry going to help research? Right? How is this registry going to help the future of Parkinson care? And I think for that, we kind of have to take a step back and understand Parkinson's is a unique disorder, what I like to call a designer disease, right? There is no biomarker for Parkinson's disease. It's a clinical diagnosis. You come to the office, you might have a little bit of tremor, dragging of one side, reduced arm swing, and you make a clinical diagnosis of Parkinson's. There is no blood test for Parkinson's. There's no MRI that helps us understand this is Parkinson's disease. Very much unlike something like diabetes, for example, where you can check a blood sugar and know that you might be in the range of developing diabetes. There is no such biomarker for Parkinson's disease.
Right.
What if we get all this information about the registry, and ultimately it gives us some insight as to where our patients are? Is it a higher concentration in certain areas of the state? Could we even look and stratify that data even further and maybe help us give us some clues as to what might cause Parkinson's or triggers for causes of Parkinson's? Will this help us target treatments, disease-modifying agents, cures even? I think the answer is yes. But up until now, it's been a little bit elusive. Very few registries have been successful around the world for Parkinson's disease. What's exciting is that California is a very mixed population. It's a very diverse population. It's a very large population. If we can capture patients with Parkinson's throughout the state, I think that with all the healthcare institutions within the state and the support of these other wonderful organizations that are helping to support the registry, we're going to get a lot more information in years to come.
And that's great to know. And I really want to thank the community, as well as the legislators and all the advocates who have supported the registry, because, like Siketu says, this is really the first time any state has done a Parkinson's registry at this level, and it has such potential to help in our understanding. So go ahead.
So I have a question, because the thing here is that we're talking about registries not having been fruitful or successful in the past. I think a lot of it has to do with reservation on not just the provider side, but also the patient and their family side, right? When you look at the registry that tried to develop back in 2004 and 2005, and I was a fellow at that time, I remember when that was signed into effect by Governor Schwarzenegger, but it was linked and tied to the Department of Motor Vehicles. And there was a lot of reservation on patients' part that, will my name be submitted to the DMV? Will I not be able to drive? You know, a lot of Parkinson patients are able to drive. Of course, it might come to a point where they might not be able to,
Sure.
but who is the DMV to make that decision
Right.
over a medical provider?
Right.
Or over the safety as expressed by family members. So how do you not only secure this data away from other areas in state government, how do we ensure that this data continues to stay secure?
That is a great question, because I think everybody who is watching and who's part of today's meeting is going to be interested in that, whether they are a Parkinson's patient or not. Because I think a part of our basic human right is to have our private information kept private, and in ways, and have that ability to keep that private. So because of that, the California Department of Public Health and all parts of the state of California have very advanced protocols around that data security and around when it can be shared and when it cannot. I can tell you that information, anything that could potentially ever identify an individual, is not shared without a particularly special process where it goes through an institutional review board. And even then, it is tracked and is monitored. But the data is never shared with another government agency. It is never shared with, like, the Department of Motor Vehicles. It is not shared in a way that could threaten the identity of people with these government agencies, and in ways that would impair their life.
So the DMV has nothing to do with this registry?
DMV has nothing to do with this registry.
Okay.
The registry was really put in place due to the voiced and the understood at all levels need to understand the disease better and to better treat and care.
So I want to reassure my patients and my colleagues' patients that if you went to the healthcare provider, that your information will not be sent to the DMV, simply to the registry to collect this vital piece of information that might give us some insight in the future. And whether their ability to drive or not will not be reflected upon this registry.
That is absolutely correct. And I really want to echo what Cpdr just said, that this information will not be shared with the DMV and is not used in any way to inform those decisions he's speaking to.
So then who actually has access?
So at this point...
And by the way, that question was from a care partner in Vallejo, California.
Thank you. And I want to thank all those who have already contributed questions to this discussion, because our objective as the registry is to be transparent, to let you know what's happening, and to let you know what can happen with the data. So this is our data is, as I say, it's protected not only by a lot of electronic security, but there's laws in place which protect your data. Every piece of data which the state obtains has laws which have been over the years developed to protect and ensure that this data cannot be used in a way that would in any way harm somebody. So as I say, these laws get back to the 1970s, but they have been modified as electronic communication has come about. Then your ability to communicate data becomes it gets easier in some ways. So what I wanted to get to, though, is the core of your question is who is actually using the data at this point. And right now, the data is only used by people within the Parkinson's program who are working with the California Department of Public Health, and that is behind the firewalls of all the security and the computer systems that I spoke to a little bit earlier.
Now, I know that in the subtext in your website for the registry, it says that you may be contacted by a researcher in the future. What does that mean?
So what that means is a point that we have not, the registry needs to get to a point of maturity where that can actually become part of our work. But so what I'm saying is that is not happening yet. But by the statute that is in place now, there is a mechanism, and I spoke to this during my earlier slides in the beginning, where researchers who go through a process of confidentiality assurance, that confidentiality assurance goes through an ethical committee, which is composed of people from your community and people who know the law very well, that under those circumstances, a researcher can request to obtain data which they can use to contact a patient. It would be limited based on the needs of the study, but be used to contact the patient so that they could offer them the participation in a clinical trial.
This is kind of exciting to me. Now, I'm not much of a clinical researcher, but I'm sure my colleagues in academic centers who do much more research would be tickled by the idea that they could have a more homogeneous population that they could then draw from, recruit from, for future targeted therapies. Because right now, as we all know, and mentioned before, that it's a designer disease, right? Mm-hmm. Everybody with Parkinson's is a little bit different than the next person. Their response to medication is equally different. Therefore, I think this would be wonderful for the future.
And thank you, because another point I wanted to make related to that is that really it's less than 3% of people who are potentially eligible for a clinical trial actually enroll. 3%. Now, and as you were mentioning, that you alluded to really, that 3% doesn't tend to be a cross-sectional of the whole population. It's likely people who would have better access to care, maybe more educated. And so that is, like you say, one of the groundbreaking things that the registry can do, which is to make available a repository of data, a repository of patients,
yeah,
who, under the right protections, could be contacted for a study.
It's actually a little interesting that you put that 3% in perspective. That means that 3% of people who willingly volunteer to be part of a research program are the ones who dictate treatment for the 100% of all patients, right? That's
right. And it's those people who are, like you say, it's the care, it's the pharmaceuticals that are developed. That's the reason why those advocates who fought to have this Parkinson's registry implemented, the politicians who stood up for it, and the people who work hard every day, like yourself, to ensure that data is available. Well, and related to that, I wanted to ask you, looking from the perspective of a clinician who reports to the registry, what are ways that we could make it better, the registry could be improved from your perspective?
I think I'd like to see a little bit of geographic data kind of expanded. Okay. And this might take a little while, but I'd like to know, since I live and work in the Sacramento region, where my patients are in the Sacramento region, and where we could potentially sort of push our efforts when it comes to treatment in the future. But I don't think it's going to come just yet. I think that might be with the next phase. I know that there's another question here that I thought was interesting was, this is from a patient with Parkinson's from San Francisco, can we expect regular updates in the future like this?
Well, in a word, yes. And I really thank you for the question, because I want to give a little bit of background, but starting a new registry is a long process. Typically, we think of and this is a Centers for Disease Control model that we use. It takes about 5 years for a registry to actually mature. Now, we have actually been fortunate with the Parkinson's registry to have participation from people like yourself, doctors like yourself, support from the community, and a lot of electronic wizards who are able to bring more data in than would be possible probably without the computer work that's happening behind the scenes. But the regular updates are a critical part of what we will be doing with the registry. And we already actually have them out, and they're going to get better and better. On our website, which is www.cdph.ca.gov/Parkinson's. You can find information now, similar to what Tommy spoke about earlier, which we intend to expand as time goes on. In addition, we are establishing relationships and report backs with clinicians who are reporting, like yourself, so that we can provide data back to you, so that not only it's a two-way street, right? Because if you're able to get information back from us, you're able to see, oh wait, maybe I need it. Maybe I need to make this report a little bit better. I need to report more on this variable or whatnot, or maybe there's an issue. But also it informs you of what we're finding out and helps you with your practice.
I figured this is going to be a living, breathing, evolving registry, and I look forward to what future results we have, because I think it's only going to help patients and certainly help providers like myself in treating those patients better.
And I really agree, and I really appreciate, again, the fact that you've taken so much time, and your time in PANC as well as your time here today. And I realize that time is valuable. So again, I want to thank you, Saketu, for this time. I want to thank you for all your time to participate in this as the audience. And I really feel like there's a lot of ways that we as the public health and clinicians can be working together better. This conversation's actually been great for me in that sense. I hope it's been good for you in the audience as well. And I know that now it's time to move to the next part of our program. So I want to thank you for all you've done.
Well, thank you very much, Mark. It was a pleasure being here, and I really like how we both were able to understand the registry a little bit better for our audience. I think that this is not only helpful to the two of us, but also helpful to everyone in the audience, both patients and care partners alike. So thank you so much.
And with that, I want to introduce again the president of the Parkinson's Association of Northern California, Mr. Sean Tracy. Sean?
Thank you. Wear your mask. Thank you, Dr. Damson and Dr. Kandar. Really appreciate the education and experience and wisdom and perspective about the California Parkinson's Disease Registry. It's critical now that we take this information, this education, and get the word out. I would encourage you to wear your mask, show everybody what it's all about, and so they'll ask questions. What is that? How does that get involved? What can I do to help you? We have a better understanding about the benefits and have a better understanding about how we can shed the light on the Parkinson's Disease Registry. More to come. And if you were here in person, give you the big virtual hug, I'd give you the high five, give you the fist bump. But until then, until we can get together and we're all safe and we're past this COVID season, which we will be, I want to thank you for your time today. And then I want to introduce someone who's very special to us, our new executive director, Barbara Fleck, who we just hired in April, and she's done a dynamite job. So if you have any questions for PANC, call Barbara, she'll help. So welcome, Barbara.
Wasn't that fantastic? Thank you guys for joining us today. I know how important it is for you to learn about Parkinson's disease, and so glad you could come today and join us. This registry is a great instrument for us to collect data, to learn about commonalities, and to potentially obtain a better understanding about this disease. Another opportunity that I want to invite you to, and I hope you will join us, is our upcoming PANC annual virtual conference. This year's conference will be held virtually for the safety of our attendees. Please join us as you have today also. You're going to learn about treatment from national and locally renowned speakers and Parkinson's disease experts. Some of the topics that you'll learn about are young onset Parkinson's disease, how sleep affects you when you have Parkinson's disease, neuromodulation, motor fluctuation, and dyskinesia. I hope you will join us on Saturday, October 24th, 2020. Please visit the PANC website at painttoday.org to register and for more information. And thank you again for being here.